Hello, welcome to Atropia Medic School. Today we're going to go over a series of 5 questions on cardiovascular emergencies. There will be a follow-up video to this going through 5 or 6 more questions on other ancillary topics. This first video is more focused on acute coronary syndrome type questions, so let's get started. All right, first question. What best describes the pathology of acute coronary syndrome? A, there is an electrical disturbance of the heart. B, there is immediate cardiac arrest. C, there is an occlusion of one of the heart's arteries. Or D, a clot has formed in the blood vessels of the lungs. So take a moment and think of your answer. And the correct answer here is going to be C. So acute coronary syndrome is something that the AHA, the American Heart Association, likes to quote. It refers to a few things. So it could refer to angina pectoris, particularly when we think of this, we think more unstable, meaning that the chest pain doesn't really just go away with rest. It takes a lot more treatment in order for that chest pain to go away, but there's no acute occlusion of an artery. This could refer to something called an NSTEMI or a non-ST elevated myocardial infarction. So there is heart muscle tissue death. That's what myocardial infarction means in medical terminology speak. But it's usually a small blood vessel involved. It's not producing these very significant EKG changes that we see with our classic myocardial infarction. It could also refer to what we call a STEMI, ST elevated myocardial infarction. This produces a very classic EKG picture that we associate with heart attacks. So acute coronary syndrome refers to, it can refer to any of these, but more importantly, what it's describing is there is some occlusion of some variety in the blood vessels of the corner of the heart, the coronary arteries, and as a result, it is causing problems. For example, chest pain. Next question. Which best describes the chest pain experienced due to an ischemic heart event? A, pressure-like pain radiating to the arms and neck. B, palpitations. C, tearing pain radiating to the back. Or D, sudden onset shortness of breath. So take a moment to think of your answer. And if you picked A, that is correct. Whenever I tutor students, I always like to refer to A as classic cardiac chest pain. CCCP, I guess you could make a communist joke there too. But I like to call this classic cardiac chest pain because this is what we think of for ischemic events. So we were just talking about acute coronary syndrome. This is the kind of stuff that I associate with acute coronary syndrome. So pressure like squeezing, elephant sitting on your chest, oftentimes we like to think classically radiating down the left arm, but it can radiate down either arm. It can radiate down both arms. It can radiate up the neck to the jaw. So any of those are possible. Palpitations, that's just when you feel your heart beating out of your chest. Again, could that happen here? Sure, but it's not classic for like ischemic cardiac type chest pain. Tearing pain radiating to the back. This is more indicative of an aortic aneurysm, which we'll talk about in another video. But that tearing pain is more indicative of that. And then sudden onset shortness of breath. This is what we think more of with like a pulmonary embolism. Although other things can cause sudden onset shortness of breath for sure, but one of the things that definitely I want to rule out because it can be deadly is a pulmonary embolism. And so sudden onset shortness of breath is one of the things that kind of clues you into that. Could that also happen with classic cardiac chest pain? Sure. But again, the pressure like chest pain radiating down the arms and up the neck, that's definitely something that should tell you, okay, ischemic heart event going on potentially. All right, question 3. An alert 50-year-old male calls for radiating chest pressure to the arms. You note the patient is pale, cool, clammy, and tachypnic. You should A. Administer 0.4 milligrams nitroglycerin sublingual. Administer 324 milligrams of aspirin orally. Answer B. Answer C. Administer oxygen via nasal cannula. Or D. Administer BVM ventilations. Take a moment to think of an answer. And our correct answer here is C. So when we look at questions like this, we don't have that much information to go off of. But one thing we note is that they are giving us a lot of stuff that we would pick up in the primary assessment, where you're assessing for ABC life threats. Primary assessment. And so if we're in the primary assessment in a question like this, they don't give us vital signs. They don't give us medical history or much in the way of like OPQRST, other than the very basics. They give us just bare bones. This is what you're walking into, and you see that the patient is tachypnic. That is pretty indicative of you are at the beginning of your assessment, so you have to address ABC life threats first. In order for me to be comfortable giving aspirin or nitroglycerin, I need a couple things. Ideally, we need to get a sample history, or we need to get more of OPQ, RST. Because remember, like, I don't want to give nitroglycerin or aspirin to someone having tearing chest pain radiating to the back. Those are two, there are two different things going on here. The way this patient's presenting sounds more ischemic, but we want to do our due diligence. We need a little bit more information before we just throw out our medications. Not to mention, we need vital signs, especially important for nitroglycerin. Anytime you want to give a medication, you really should be you should be obtaining vital signs, especially blood pressure. Because as we know, nitroglycerin will lower your blood pressure, and we don't want to make someone who's already hypotensive or borderline actually worse. Now, tachypnea means elevated respiratory rate. That's all it means, right? So when we see tachypnea, that just means elevated respiratory rate. This patient is alert. I know they appear in shock, but they're otherwise alert. They're tachypnic. They're not writing anything like we explored in our respiratory failure and oxygenation quizzes or our airway quizzes. There's no language here suggesting respiratory failure. I would say they're at best in respiratory distress. So we don't need to flood them with oxygen. We don't need to start BVM ventilations. This would really be for someone who had a low respiratory rate or a respiratory rate above 30, if they were shallow breaths or intermittent, things like that. So we don't need to do the BVM ventilations. Now, I know we don't have an SpO2. Whatever, that's fine. You can give oxygen to someone who you do not have an SpO2 on. That's perfectly okay. Now, would I flood this person with a non-rebreather mask? Depending on the circumstances, probably not. We know that oxygen in high quantities for a lengthy period of time can actually cause tissue damage over time. We call this oxygen toxicity. So if we can get away with just using a nasal cannula, that's a good first start. If they're not tolerating it well, fine. Bump up the oxygen to a non-rebreather mask. But the vast majority of your patients in real life will tolerate the nasal cannula just fine. It will fix a lot of issues. You'd be surprised how a little oxygen can go a long way. So let's give them a little bit of oxygen, see if it helps. But again, that's not the crux of everything here. All right. Next question. You are treating an alert 55-year-old male with ischemic chest pain. I feel kind of discriminatory here. Maybe there should be a female instead. Anyways, the patient has their own nitroglycerin prescription and no known allergies. The vital signs are heart rate 70, blood pressure 86/60, respiratory rate 20, SpO2 98% on room air. All the following are correct except A, administer aspirin 324 milligrams orally. B, administer 0.4 milligrams nitroglycerin sublingually. C, oxygen administration has limited benefit in this patient. Or D, the patient should be transported to a hospital with cardiac catheterization capabilities. Take a moment, think of your answer. And answer B here is correct. So remember the root question. I'll highlight it here in yellow. The root question here is all of the following are correct except. Some students I've worked with actually find it really helpful to first identify their root question, what is actually being asked of them, before going back and reading the actual scenario. Some students really like reading their answers first and then going back to the question. In any case, what we are answering here is the root question. And this is what I like to call an inverse root question. Inverse. I can spell, I swear. Apparently I can't spell. Sorry, guys, I can't spell. Inverse root question, meaning they're asking something kind of in an opposite way, like all the following are true except which of the following is false regarding XYZ. So, a good rule of thumb to also keep in mind is when you have vital signs, pay attention to the vital signs, because what the vital signs are telling you is either you can or cannot do something. So we can see here that this blood pressure is not great. This patient's hypotensive. And a general rule of thumb with nitroglycerin is they need to have a blood pressure greater than or equal to 100 millimeters of mercury systolic. So their top number. Their top number needs to be at least 100. And it's not. So we don't want to make them worse. We definitely should give this patient aspirin. That makes sense, given their complaint. We can see that their O2 sat's great. Could we give them O2 if we really wanted to? Sure. Is it going to do anything? No. So if they're not complaining of any respiratory stuff and we see that their O2 sat's 98%, anything that's 94% or above is fine for us. We technically don't need to give them oxygen at that point. And we definitely need to transport this patient to a place that has a cardiac catheterization lab. You'll hear it referred to as a cath lab in kind of, the common parlance. The reason why we need to do that specifically is not every hospital is capable of doing coronary stenting, meaning they actually put essentially this kind of like mesh that expands open to reopen a blood vessel. Not every hospital can do this. Only hospitals that have cardiac catheterization labs can do this. So wherever you work when you get licensed as an EMT, you will learn which hospitals have those capabilities, which ones don't. And when you get patients with chest pain, you should be bringing them to the hospitals that you do know have that capability. All right, final question here. A patient with radiating chest discomfort to the jaws and arms for the last hour without allergies is more likely to survive an ischemic coronary event with the administration of A, aspirin, B, nitroglycerin, C, high-flow oxygen, or D, heparin. Take a moment, think of your answer. And A is going to be our best answer. So aspirin is statistically known to reduce morbidity and mortality, meaning they tend to have less adverse issues after their heart attack, and they're less likely to die of a heart attack after being given aspirin. Why is that? Aspirin acts as a platelet inhibitor. We'll put this here in yellow. So it acts as a platelet inhibitor, and I apologize. I'm on a GroupMe chat with a whole bunch of other people. They're blowing it up. So if you see those messages pop up, that's why. But anyways, aspirin functions as a platelet inhibitor. Now, we know that it is an NSAID. It's a non-steroidal anti-inflammatory medication, or kind of in the same vein as ibuprofen, naproxen, or Aleve. But aspirin in particular has a lot of platelet inhibition properties. They all do, but aspirin's the biggest one. And what this does is it prevents platelets from sticking to the injured blood vessels that are all plaqued up, making that partial occlusion into a worse full occlusion, or, a mostly occluded blood vessel into a very, very much 100% occluded blood vessel. So aspirin is very important from preventing that from worsening. It's not going to reverse it. It's not going to reverse that plaque buildup or anything, but it's going to prevent that partial occlusion from potentially turning into a deadly occlusion, at least statistically. Now, nitroglycerin, it's a nice medication to give. We do want to solve people's chest pain if we can. Oxygen certainly can help with reducing chest pain, but it doesn't necessarily reduce morbidity and mortality. But nitroglycerin, it's a nicety, but it's not going to save anyone's life. It's just reducing the perceived chest pain. And it really works just on collateral circulation. So if you have a very occluded blood vessel, nitroglycerin is not going to vasodilate open that occluded blood vessel. It's just allowing all the other arteries in the heart, the coronary arteries, to get perfusion, or at least more perfusion. It's not going to fix the underlying issue. Same thing with O2. It doesn't fix the underlying issue. It may help, but it's not going to fix the underlying issue. Heparin is not an EMS medication we play with. At the paramedic level, you may be asked to transport it, but as an EMT, and this is what this is focused on, is we should not be picking answers that are not within our scope of practice, unless if they're asking which one of these things can you not do, right? But heparin is not necessarily going to save this patient's life either the way that aspirin will, because this is more particular a platelet issue, not so much a clotting factor issue. Heparin, for those who are curious, it's actually an anticoagulant, so it works on clotting factors, which is a complementary but separate system from how the platelets work. So they work together, but they are separate systems. So here's 5 questions that we went through on some basic acute coronary syndrome stuff. If you have suggestions or comments, feel free to leave them, like the video, subscribe, and we'll see you next time.